The best metric of toxicity is discontinuation.
Right.
And if you can't take it, it wasn't tolerable. I want to share with you the familiarity that we've built with bevacizumab. In our first trial, GOG-218, which led to the FDA approval, the discontinuation rate due to toxicity, predominantly hypertension, was 21%.
Yeah.
So now, 6, 7, 8, 9, 10 years later, we're better at it. The discontinuation rate to bevacizumab is only 6%.
That's right.
But olaparib added another 14. I get it, we're getting better at PARP inhibitors too. How does that play into your temptation to want to use combination that a fifth of the patients aren't going to be able to tolerate it?
I think it's a great point because I agree with you. It's, patients vote with their feet. And so when they don't like something, they stop it. And they go see someone else sometimes. So I think that's really accurate. I do want to look at the manuscripts a little more carefully because in Paola they combined.
So this has not been published yet. So
Right.
this
That's
is
right.
different than the other two. Keep going.
They combined because the PI told me this, they combined a lot of, in Solo 1, for example, we had discontinuations due to treatment emergent adverse
Right.
events. We had physician decision, we had patient decision, unknown. And really, why do patients come off? Usually because they have a toxicity, it just wasn't enough to
Call it
warrant
whatever you
discontinue-
want.
Yeah.
But they discontinue. So if you add all of those up across these studies, it may be pretty close to 20% of patients discontinuing for some reason. And so I kind of want to look at that before I really raise the flag on the Paola discontinuation. It may be real, so I want to go on record as saying that, but I also think there may be something in how it was reported.
But don't you think we get better at it? You already made that
I do,
point,
we do
right?
get better
The
at it.
We definitely
Bev
get better
was about 20%
Right.
when we first started using it, and now it's about 6%. So we just need to get better at giving the combinations. We need to make sure we're acting quickly to, mitigate adverse events and keep patients from saying no more.
And it also may be, to your point, and I agree with what you just said, even though this is all exploratory, there's patients who benefit from bevacizumab and all the other exploratories analysis, ascites and all these things. They are going to feel better on Bev as opposed, and they know, because you counsel them, or you hope you do, as opposed to patients who maybe would still benefit some, but they're going to do fine either way. Paola had all of those patients, so if they're like, I feel pretty good, I'm just coming off, as opposed to someone who was like so freaking sick and now they feel better, they don't stop. Those patients that you kind of rescued.
Right.
So it's a different, it may be a lot of patient selection of who we put on this combo and they stay on when they don't want to go back.